grateful for technology to bring us together. So I'm going to tell you about the work that my lab and my colleagues are doing around how social connection can be a form of medicine for suicide prevention, as well as promoting health more generally in later life. And I am part of the Center for the Study and Prevention of Suicide at the U of R, and just delighted to be here with you all. So what I'm going to talk about today briefly are three topics. First, some background on social disconnection and its link to suicide risk. Then I'll shift briefly to talking about safety planning specifically for older people as a means to target not only social connection, but other leading risk factors for suicide in later life. And then I want to turn to some work that we're doing around connection planning, which is meant to be analogous to safety planning, but specifically targeting social connection as a way to reduce suicide risk. And I will say up front, I have more content than I'm going to be able to get through today. But the reason I kept all of that material in there is I'm going to give you a link at the end of the talk to download these slides. You can go into a little more detail on the parts that we don't dive fully into. You can also keep track of some of this stuff. If you want to spend more time on it, let me know in the Q&A and we'll come back to it. Okay, so to start, why we need to be talking about suicide specifically in older people. Well, one, we know that our population globally is aging, meaning that we're living longer. And so we have more people who are having the privilege of living into later life. Older people are the most rapidly growing segment of the population. Also, unfortunately, suicide rates increase with age globally, especially among men. As well, one of the reasons why rates are so high in this population is that older people are more likely to die when they make a suicide attempt, in part because they tend to be more planful and to use more immediately lethal means, which where I am in the US is firearms. I also always like to start my talk with a reminder that even though suicide rates are very high in older people, depression and suicide risk are not the expected responses to the stresses of aging. In fact, there's really neat, compelling data from gerontologists and geropsychologists and geriatric psychiatrists showing that emotional well-being on average actually increases with age. We tend to get better at regulating our emotions, at paying attention to positive things, and at enjoying and appreciating our relationships as we get older. So in fact, social connection is a strength of aging. And so the reason I like to talk about it is that it's a strength that we can capitalize on to hopefully reduce suicide risk. And that we then need to remember that our goal in helping older people is to actually just course correct, meaning adjust or try to get rid of those risk factors to get someone back on the normative developmental pathway in later life, which is towards greater emotional well-being and greater satisfaction with social relationships. So first off, social disconnection and late life suicide. So as you got from the title of my talk, the main thing I would love for you to take away today is that we can think about social connection as medicine for ourselves, for our patients, for people we work with. And that seems kind of like maybe a throwaway phrase, but it's not, because when I work with older people, I want them to think about having a social connection a day the same way they think about taking a pill or a medicine in the morning, because there's so much research showing that social connections that create a sense of feeling cared about, of giving back, and of being part of a community have a range of benefits for health and well-being, and even how long we live at all ages. And why do we focus on it in later life? Well, one, it's a strength, and two, social connection remains malleable throughout the lifespan. There may be certain things in my older patients that I may not be able to change, such as cognitive decline, but all of us can always work on improving our relationships. And briefly, I want to get us on the same page about terminology. So when I'm talking about social connection, what do I mean? This is a framework that was developed by Juliana Holt-Lundstedt, and it talks about three different types of social connection. So social connection being this kind of umbrella construct that includes a couple things. And these are aspects of our social relationships that have been demonstrated time and time again to be associated with our health. The first is the structure. You can think of this as things that you can count, like the number of people in your life, how often you talk to them. And you can see there the pictures of a network. So all those dimensions of relationships that you can count. Second is the function. And the idea here is that social relationships do things for us. They serve functions in our life. That can be support, emotional support, instrumental support, all the things that relationships can do for us. And finally, subjective, how we feel about our connections. And this is, I'll mention just briefly, one part where I tweak Juliana's model a little bit so that it works a little bit better for my interventions, whereas she thinks about loneliness as being part of the functional dimension because it meets that need to belong. I tend to think about it as falling in the subjective dimension, meaning how we feel. So not just quality of relationships, but if we feel like we're isolated or we feel connected. So I think about belonging and loneliness under that third bucket of the subjective dimensions of social connection. So moving forward a little bit, I'm going to give you a little bit of the data linking to suicide risk. So social connection is protective. So socially connected older adults in these two studies that I have listed below actually have a twofold reduction in suicide risk over the long term. This is a big effect and it persists. As well, we can think about the flip side, so social disconnection. So I tend to use the term social isolation and loneliness. Again, this was coined by Juliana Holt-Lundstad and her colleague Carla Parasinotto, who is a geriatrician. And they talked about this and published a paper in the New England Journal of Medicine that used that term. And what I like about it is that for a lot of the health outcomes that we're interested in, both isolation, which is a structural or objective measure of connection, and loneliness, which is more subjective, they often have similar links to health outcomes like suicide. And so when there isn't a meaningful difference between the two, I'm going to use the term SIL. There are definitely differences in terms of how we experience them and how we might intervene. But so that we don't get bogged down and make the conversation flow a little easier, when I'm putting them together, I'm going to use SIL. And just to give us a sense of how common this can be, up to 45% of older people will experience social isolation and loneliness. I will say, though, it's important to keep in mind that when we look at studies across the lifespan, younger people tend to struggle more with this than older people. So this is not a problem of later life, but it is an opportunity to prevent suicide in later life. Here are some ways that SIL might show up in an older person or a younger person. So these are all dimensions of social connectedness that have been linked to suicide deaths in older people. Living alone, having a small network, not having a confidant, someone to talk with about things that are troubling you, losing a spouse, social withdrawal, so withdrawing and isolating more, family discord, so having relationships that are with conflict, loneliness, and low social integration, all linked to suicide deaths in later life. As well, here is a statistic looking at disconnection. So the other study that I presented for you was looking at high connectedness, but lacking connectedness is also a potent risk factor for death in later life. If we look at it compared to other characteristics of older people who die, around 70 to 90% of suicide deaths in older adults occurred in the context of social disconnection, and it's listed as a key circumstance contributing to suicide in the death certificates in 39 to 42% of suicide deaths. So this is a very common characteristic among people who do die by suicide in later life. And again, I am going to give you a link to these slides. If any of these citations are useful for you, you'll have them. I want to turn briefly to potential explanations for why social disconnection may be linked to suicide deaths in later life. And in particular, a lot of my work is grounded in the interpersonal theory of suicide. I was lucky enough to join Dr. Thomas Joyner's lab right as he was developing this theory, was able to take part in developing the assessment measures for these constructs, and also to help with refining the theory towards making it a little bit easier to test and falsifiable. So what you see on the figure is kind of the premise of the theory that when we feel like we don't belong and we feel like others would be better off if we were gone, the theory posits that is when a strong desire for suicide emerges. But crucially, the theory also says that thankfully it's not enough to want to die. Someone also needs to be able to die. They need to have the capability. And the theory says that that shows up as reduced fearlessness about death, and then also having access to the means or the practical capability to do that. And so what you see there, a key premise of the theory is that it's the intersection of all three of those. So in the moment where someone's in a suicidal crisis that may result in death, the theory posits that they're feeling alone, like they don't belong to valued relationships or groups, that they're alone in the world. And crucially, that others be better off if they were gone, and that they have some reduced fearlessness of the method that they've chosen. And so when all of those three come together, the theory posits that that might be when someone is at greatest risk. The piece of the theory that's not on the picture, because it gets complicated with lots of moving parts, is the idea that all of those indicators of social disconnection on the left that are linked to suicide deaths are linked to suicide deaths because they may lead to or cause or make someone vulnerable to experiencing low belonging and perceived burden. So living alone or a loss of a spouse, for example, the first two on the list, are more distal factors that lead to these proximal experiences that someone experiences in a crisis that are then proximally linked to suicide deaths. So there's a lot there, but the point to say that all of these indicators of social disconnection, the theory says that they cause suicide deaths via, or the mechanisms are low belonging and perceived burden. And I'll try to come back to some of that in the Q&A if anyone has questions. And so what I was saying there about social connection being proximal, that's kind of underlies all the work that we do in my lab as social connection as a mechanism to reduce suicide risk. And a key part of this, or the premise, is that there actually have been only 3 studies, at least that I'm aware of, that have shown effects on suicide deaths in older people. All 3 of them involved promoting connection in some way that was a shared intervention component. But unfortunately, the studies were not designed to test these mechanisms. The interventions were multi-component, which is great because that's likely what is going to reduce suicide deaths, but it doesn't allow us to test the mechanisms. So that's the work that my colleagues and I are hoping to do, is to build on the strengths of these studies and the amazing foundation they laid for us to see if we can actually demonstrate and show that changing social connection may be a key mechanism to save lives. So I'm going to turn now to how you can take some of that information and hopefully apply it in your work with people that you work with. And I'm going to talk briefly about safety planning. I know that this is not going to be a new topic to anyone, but I want to lay some foundation for how you can specifically use what we know about the epidemiology of late life suicide, including social disconnection, to hopefully really optimize safety planning to make it especially relevant for your older patients. So here is a resource that my colleague, Elizabeth Conti, developed, and I think it's just wonderful. It's a wonderful resource that's free. It was developed by the VA, but it is online and freely accessible. And what it is just a short sort of workbook to go through how to do safety planning in a way that is really accessible to older people, and hopefully something that they will then really want to be able to use. And so while the sort of most common form, at least in the US, that we see is the Barbara Stanley and Greg Brown version, when I talk about safety planning, I always remind folks that it's not about that particular form. It's about the principles underlying safety planning, and it doesn't matter which worksheet you put it on. And so this collaborative safety planning for older adults workbook kind of goes through how you can make this work for older people, including simple things like putting it on a bigger piece of paper with bigger font. And so I'm going to show you a little bit about what that looks like. It uses these same aspects of the Stanley Brown safety plan, but then helps you deliver it in a way that will meet the needs of older people, including if they have some mild cognitive impairment or some sensory impairments. And what we did is with Elizabeth and others, we wrote a paper that I think is very useful. I use it when I train folks in my health system to do safety planning with older people. And so we took that framework that's in that workbook, and then we applied it specifically to the risk factors for late life suicide. And this article is available for free in PubMed Central. You don't need any subscription to download it. And so that paper and what I'm going to talk to you today is grounded in what my colleagues and I call the 5 Ds of late life suicide. And this model was developed by my colleague and mentor and friend, Yates Conwell, who taught me everything I know about suicide in later life. And he talks about these characteristics of older people who die by suicide as the 5 Ds, because all of them begin with the letter D. And what's really nice about this model is it's very simple. It's also very clinically actionable. So the work that Yates and his colleagues did on psychological autopsies in later life really laid the foundation for a lot of what we know about late life suicide prevention. And so they were able to talk of next of kin of individuals who died by suicide and start to understand what those people were experiencing in the months and weeks and days before their death. And what they found was these 5 factors were very, very common in older people who died by suicide. Many had all 5. And so the model says that when someone has more of these factors, their risk increases. So just like the Venn diagram with the interpersonal theory, we see the same thing here, where if an older person has more of these factors, their risk will increase. And I'm going to go through each of these briefly, and describe what the literature has shown, and then also how you can use it in a safety plan, because these are very potent intervention targets that are very much grounded in what we know about suicide in later life. So I'm going to start with disconnection because I've already gone through what that looks like and how it may be shown in the literature and how you can use it here. And so there are some resources I'll call your attention to at first on the top left, which is the US has a wonderful resource called Engaged, which is the National Resource Center for Engaging Older People. And there are all kinds of amazing resources on there, including different sort of models that are being used for social connection for older people. But if you were thinking about working with an older person and wanting to put a few things on a safety plan because a person who you're working with is experiencing loneliness or isolation, and that's really driving their suicide risk, what could you do? Well, one main thing is letting the older person know, or a younger person, that social connection is a form of medicine, especially for suicide risk. So connection is not something that's like an extracurricular or a nice thing to have. It's actually essential. We need it just like we need food and water, like I need my coffee, kidding, how we need our housing, all of those things. We are social creatures. We have a need to belong. And if that need is unmet, health consequences happen, like thinking about suicide. So social connection is medicine. And one of the most potent things we can do is be proactive. It can be really tempting to be passive and wait for people to reach out to us. So how we can use connection as medicine is to push ourselves just a little bit to be proactive. So reach out to friends or families. There are warm lines. Even things that don't involve being face-to-face with another person can be potent ways to target disconnection. So what do I mean by that? Writing an email, writing an old-fashioned letter or a card, even planning future activities gets our brain out of that isolation time and into connection time. So things that help you be proactive and create connection. For an older person who might be experiencing deep loneliness in the context of grief, we might think about paying attention to that grief, not dwelling in it or being overwhelmed by it, but acknowledging it. in gentle ways. Things like journaling, if people appreciate prayer. There are containment exercises from the trauma literature that can help if the grief is getting too intense and it is overwhelming. Another strategy is just be around people. So if someone's been isolated a long time, joining a new group or going to a senior center and interacting can be a lot. So instead, it can be around people. So yesterday was the day before yesterday was the first warm day we've had here in Rochester, and probably for you all too. And I went for a bike ride, and so many people were waving and saying, "Oh my God, the weather's so nice!" And that was a great way to connect around shared interests. But I wasn't having these long conversations with people; I was just waving. And so being in a common area, if someone lives in senior housing, even listening to the radio, going to a coffee shop, when you get your groceries, actually don't do the self-checkout like I do, talk to someone. Sit on your front porch and wave. My colleague Karen Fingerman in Texas has done some really compelling work showing that these, what we might call superficial ties, actually have big benefits in later life for health in terms of physical health, but also mental health. So while they're not ongoing, lasting relationships that are going to, change longstanding loneliness, they actually can very much take the edge off of isolation and give us moments of connection. So please don't discount those, and please help the people you're working with realize their value. Finally, on a safety plan, you might think about addressing barriers. So doing some brief problem solving, providing education to resources for things like transportation assistance are not only useful for addressing the barriers, but can give someone a little bit of agency and a little bit of hope that can maybe help them get out of a suicidal crisis. Okay, I'm going to briefly turn to the other of the 5Ds, but I'm going to spend a little less time here. So remember, you're going to have these slides to download if you'd like to dive into this a little bit more. I do want to mention that depression is even more common among individuals who die by suicide. The proportion is greater than at younger ages. Treatment is rare. Few older people get specialty mental health care. They often will get that care in primary care. In later life, depression and comorbid with medical conditions is the norm, and depression sometimes looks a little different. So feelings of apathy or not enjoying things are much more prominent than sadness or depressed mood in older people. And concerns that older people present with are often more grounded in somatic symptoms, things like sleep or fatigue, and cognitive concerns as well. So it can show up a little differently in later life. And so how would you target depression in a safety plan if this was someone's perceived driver of their suicide risk? So simple things like scheduling pleasant activities. You might manage things like irritability with self-soothing. To address apathy, if you can, enlist the family. So working with older people shares some similarities to working with youth in that it's very hard to do well without engaging the family if there are family supports. So enlist the family to get it started, or even start your pleasant activity in a session. Finally, insomnia through brief sleep hygiene, and also collaborating with the primary care doctor to see if there are any medicines or health conditions that may be maintaining difficulties with sleep. So the D for disease is physical illness. And what we know about this in older people is that it's multimorbidity. So it's not just one chronic illness, it's many. Even 7 or 8 are highly linked to suicide deaths. We also know that, yes, physical illness and multimorbidity is common in later life, but we do see a decline in health in the year prior to death. Like I said, with sleep, poor sleep quality is a very common presentation, and primary care is essential. So most older people who die by suicide are seen in primary care in the weeks and months prior to their death. Very rarely do they come in saying, "I am having thoughts of suicide." But they are having these declines in health and things that are concerning, and they do tend to show up in primary care. At the bottom, a few things we don't know yet. There's a lot of inconsistency in the research around which specific illnesses or organ systems are most common or most potent in terms of suicide risk. It does also seem like some illnesses may be more linked to ideation versus behavior, but there's a lot of inconsistency there. And then likely there's multiple mechanisms whereby physical illness or disease is linked to suicide deaths. It could be likely the neurobiology of the illness plays a role, but also the stress from the illness and functional impairment. So many, many different mechanisms, and we're still learning exactly how physical illness may be linked to suicide deaths in later life. Okay, so how would you manage that in a safety plan that's really about mental health? Well, helping the older patients see that attending to their physical health is attending to their mental health. They're so linked. And if we think about the 5Ds model, addressing physical health is absolutely a way of reducing suicide risk. So things like doing your physical therapy exercises, making a doctor's appointment if needed. I'm going to skip to managing physical pain. So doing things to manage pain, in addition to the work that someone may do with their physician to reduce pain, there are relaxation exercises, distraction, and taking medicines as prescribed. The other things are more mental health focused, so focusing on meaning, activities to refocus our attention on what matters, what gives us meaning in life, and managing hopelessness about physical illnesses. So listing helpful thoughts that might help someone hang in there in the context of managing a challenging physical illness. Okay, so we're to our fourth D, which is disability. So we've done depression, disconnection, and disease. Now we're to disability, which here we're talking about another term is functional impairment. So activities of daily living and instrumental activities of daily living, having more of those challenges is linked to suicide deaths in later life, as well as sensory impairment. So difficulties with hearing or vision. In particular, the psychological autopsy studies have shown that assistance with activities of daily living is particularly linked to suicide deaths, including when they're to the point that someone requires, say, a visiting nurse or a home health aide. And so the activities of daily living are the more basic things, like being able to attend to your hygiene, toileting, getting dressed. Instrumental activities of daily living are the things that are a little more cognitively complex, things like managing your groceries or managing your finances, getting organized to have people over for dinner, things like that. And then finally, what are some of the potential mechanisms? Well, it appears that individuals who have certain personality characteristics, like a high need for control, when you combine that with a functional impairment, which someone can't control, that's a really dangerous combination. And then having lack of flexible coping to manage that. And then finally, there's newer research that's really compelling, showing that internalized ageism is linked to a decreased will to live. So ageism is one of the isms, just like others, that which speaks to the idea of bias and stereotype. And this time talking about aging and negative attitudes towards aging. And our society gives it to us all the time. And when we take that in and believe it for ourselves, that can really lead to potential suicide risk. So believing things like later life is a time of loneliness and despair. You can see how someone, if they're really holding that as true, would have trouble engaging in all the things that might help them feel connected to life and to the people around them. So how do we target disability independence in a safety plan? Well, if perceived burden is showing up, remember from the interpersonal theory, believing that others would be better off if you were gone, if that's showing up for someone in the context of needing help with activities of daily living, so they're distressed about dependence, we can address those. So what would I tell a friend? Helping someone start to understand just a little bit that someone's illness can cause a burden, but that doesn't mean that they as a human being are a burden. There can also be doing opposite. So if you know and love DBT, you know about acting opposite to emotions. So you can do that by focusing on contributions that you make and that you value. So helping and supporting others can really help with feelings of dignity and counter perceptions of burden. Finally, this can also be a place where we might look at distress tolerance exercises or meditation and acceptance. If someone's struggling with countering perceptions of burden by talking back to thoughts, maybe helping them change their relationship with those thoughts. Imagine watching them on clouds, right? They're thoughts, they're not facts. And then finally, problem solving. So if there are resources that could help someone, things like having someone come help with things or transportation, then absolutely enlisting those things can be useful as part of a safety plan. Finally, the fifth D is deadly means. So we've done depression, disconnection, disability, disease, and now we're to deadly means. So like I mentioned, suicide attempts are more often fatal among older adults. And so what we need to do then is to put a speed bump in place between an older person and that method. We need to slow them down. We need to have some things in place that can hopefully reduce those highly lethal means. So it can be firearms, but in other parts of the world, it might be lethal pesticides. So we know characteristics of those who die via firearm, at least in the US, tend to be those who live in rural areas and have military service. But in other places in the world, such as maybe rural China, those pesticides can be key. So anything we can do to help an older person slow down their access to those means can be really important. So a firearm, a lock on the gun, for example. We also know that having a firearm in the home has been shown in psychological autopsies to be a very potent characteristic of people who die by suicide. And if you combine that with cognitive control deficits, where someone might act more impulsively in the moment, that is a really dangerous combination. Okay, so targeting deadly means. Any sort of means restriction or means safety can be a challenging emotional topic, especially if we're talking about firearms. So I have a resource there for you on the left of the slide, the Firearm Life Plan, that I like a whole lot. It feels very non-blaming, and it's very much about firearms are something we need to plan for, just like we do with our estate, like thinking about our house. It also discusses firearm safety, not just in the context of suicide risk, but also in the context of aging and dementia. And it can help people walk through a plan to think about how to manage firearms in a way that will keep themselves safe, their grandchildren, everyone in their home. There's also information about lethal means counseling through the link from Harvard that I also think is really good. Finally, enlisting family is really important for things like safe storage of medications, removing lethal means, plan check-ins. So with my older patients, even if I'm doing DBT, I don't rely on them reaching out to me. Older people that's just not something that comes naturally. It's something that often I need to help my older patients practice and learn to become comfortable with. So instead with them, I do plan check-ins. If I'm their therapist, I'll plan for them to check in with me. I'll reach out to them. They might also plan check-ins with family, neighbors, or other providers. Finally, if you can remove alcohol during crises, removing alcohol can be very helpful because alcohol can be a way to reduce fearlessness. So remember, I talked about capability for suicide. So someone may drink alcohol and that can give them that fearlessness that is part of capability. So if we can remove that, that's very, very helpful. Okay, so I flew through that for you. So we can definitely come back to any of it during the Q&A if you'd like, but I want to turn now to upstream suicide prevention. So we were just talking about safety plans of something we would do with an older person who's either had a suicide attempt or thinking about suicide. And so it's a robust part of a plan for safety management. But what could we do in order to prevent older adults from getting to a suicidal crisis? That's really an important part of suicide prevention in later life, because as I mentioned, most older people will unfortunately die on their first attempt. So if we only work on helping older people who've had an attempt, we're going to be missing a lot of the people who could use our help. So I like to think about suicide prevention in later life as including upstream prevention, meaning catching people before they get to the crisis, helping address any of those 5Ds before they pile up and before someone gets to a crisis. And so my colleagues and I developed connection planning during the pandemic when we realized, there are no clear evidence-based interventions for loneliness. Not yet. There's signals of things that may work, and there's definitely data showing that we can change loneliness. But the literature's not clear yet on what the best programs are and how to offer them and to whom. And so what we did is we said, we do have some clues from the literature. So let's take what we know about what works and put it in a package that can be brief and delivered in places where older people show up, like primary care. And that builds on the same skill set as safety planning. So if someone knows how to do a safety plan, they can really quickly pick up connection planning. So I'm going to turn to that for you now and tell you a little bit about it. So we do have a manuscript that we published that is available for free in PubMed Central. So you can download that at no cost. It's in the American Journal of Geriatric Psychiatry. And like I said, it's analogous to safety planning. And so it can be a standalone intervention that you might provide, or if you're providing psychotherapy or peer support even, it can be part of that and can evolve. Just like a safety plan should evolve, so can connection planning. We think about it as slightly more intensive than simple recommendations for ways to connect. So, for example, social prescribing might suggest that someone go join a choir or something like that. Connection planning does a little bit more. So it helps people be intentional about connections, but that's a new thing for a lot of people. So we also address motivational barriers. And I don't mean that in a judgmental way, like someone's not motivated, more thinking about the barriers that get in the way. So things like we apply basic CBT principles to in this brief intervention that can really help someone follow through and benefit from connections to community resources. I'm going to tell you a little bit what that looks like. So there's nothing new or earth-shattering in this program. What I think we did that is nice is really bring together what we already know in a I think a pretty easy to deliver program. So it's based in the cognitive behavioral model, thinking, feeling, doing, and applying it to loneliness and isolation. So just like for depression, where what we think is really important, same with loneliness and isolation. And then a person comes away with a plan that looks a lot like a safety plan, which includes ways that they can address the thinking part of the cognitive behavioral model, the physiology or how our body feels when we're feeling lonely and isolated, and then some actions they can take. So the program teaches about that cognitive behavioral model and then helps people apply that to loneliness and isolation. And so why do we want to do that? Well, being aware of the importance of social connection is essential, and understanding what that looks like for you when you're feeling lonely. But making a change isn't simple. So by applying these CBT principles and tools, we can hopefully increase the likelihood that we can follow through with our goals, including recommendations from other people, but also things that we'd like to do. And so a little bit more on that. It's grounded in the cognitive behavioral model of social isolation and loneliness. And a big name here would be John Cassiopo's work. And the idea is that social disconnection is caused and maintained by not just objective circumstances like the pandemic or being homebound, but also by our subjective experience and reactions. So our body's physiology, our actions, and our thoughts. And so the benefit here is that by identifying what each of those three components of the cognitive model, how they show up for people, we can then identify strategies. So we can change our perspective, we can change our body sensations, and we can change the way we connect. So I think what's nice about this model is often when we think about social connection interventions, we think about having people meet new people or go to a senior center. So this model includes those things, but also addresses the cognition someone may be having as well as their physiology. And why is this important? Well, when we've been lonely a while, it changes our cognitions. Just like when you get depressed, you expect bad things to happen. When we're lonely, we expect bad things to happen in an interpersonal sphere. We expect experience and elicit more negative interactions. We're more attentive to social threats and we tend to withdraw. And so, to get someone out of a loneliness cycle, we need to attend, I think, not just to the actions, but to the thoughts that are maintaining it and to our body's physiology. So, what I have here for you that can be part of connection planning is the social pie of life. And I am mindful of our time, but I'm going to spend a moment here because it's been something that's been really useful in the interventions we do in my lab. We initially didn't have this as part of connection planning, but we've since added it. We originally did it as part of Engage Coaching, which is a one-on-one coaching intervention that's drawn from Engage Psychotherapy, which is an evidence-based intervention for depression in later life. And we added this to help people think about what's driving their loneliness. Like for me, what is it if I'm feeling lonely? What's the main cause of that? And the idea is that if you were doing behavioral activation for depression, you would realize, if I get my patient to do almost anything that they appreciate or enjoy, that will help lift their mood. The same does not seem to be true for loneliness. So a one size fits all doesn't really work. So if someone's feeling very lonely in the context of deep grief, telling them to go to a senior center is unlikely to target their drivers of loneliness. So this social pie of life is an exercise we do that can be very brief, that can help people understand their own personal drivers. And I'm not going to go into it here. I'm actually going to go to the next slide and walk you through my social pie. And I would encourage folks to try this. I'll give you a link to download the worksheet. But if you may have noticed that those 4 pieces of the pie are the dimensions in that initial model of social connection I told you about, it just breaks out support and contribution. So giving and receiving support, broke it into 2 pieces. Other than that, it's the same. So on the left, we have activities. So this is the structural dimension of social connection. So who we spend time with, how often we see them, all of those things you can count. So on the left, you see that I love riding my bike. And so I spend time with friends often when I'm riding my bike. And the one on the top left is, I was so proud of that. I rode the whole Erie Canal. And so you can see I get a lot of joy and connection from riding my bike. I also love gardening, and you see my flowers there, and I like to give them to my neighbors. And then if you move to the right, what you see there are relationships, and this has to do with the quality of our social relationships. And what you see there are a couple things. You see some of my closest friends, but you also see pictures of my cats. And so Mitzi is at the top. And at the time that I did this social pie, I had recently lost my cat Mitzi. After caring for her for 4 years with cancer, and also caring for my mom who had dementia for 4 years. And so I was in a deep spot of grief and feeling very alone, and was very resistant to the idea of adopting another cat because my heart was broken. But what you see there, you see those little goofballs in the top right. My friends were very persistent, and my colleagues as well. And they had me do an action plan that I teach in all of my interventions around whether I was ready to adopt a new cat. And as you can see, that's Maraschino, Cherry, and Sunday. They're the ice cream kitties. And I did adopt not just 1, but 2. So these interventions can be very potent. But I bring that up because one of the drivers can be grief. Whenever I talk to people about doing these social connection interventions, I remind them that we're not here to make them an extrovert if they're an introvert. We're not here to make someone change their deep nature or what they love. We're helping people get unstuck. So if deep in my heart of hearts, I didn't want to adopt a new cat, I wouldn't have. And if I really didn't want that, my action plan wouldn't have worked. But deep somewhere in my heart, I knew that having kitties would give me more energy. And so I was able to bring them into my life. Going down on the pie, you see support. And so the picture on the bottom right was when I worked at a therapeutic community for folks with mental illness, Spring Lake Ranch in Vermont. And it was a time when I felt so connected and part of community. And so for me, that's something I would like to get more of. And so it's on the pie. And then contribution is on the left. Those are all my amazing mentees who I am so grateful that I can give back to. So this can be a great exercise to do if you're not sure what you want to put on your own connection plan, or if someone you're working with isn't sure what they want to put on their connection plan. It's simple, but it breaks out all the different possibilities for what you might be able to grow and add to your life. So these are some of the barriers. I already told you about this. And you can identify that for a given person. So it might be grief, it might be living alone, but also strengths. So having good health, I'm able to ride my bike. And so look at strengths and areas to grow in, and that can help you with a connection plan for yourself or with your older patients. Let's see. So I have a lot more here that, again, I said I'm not going to go into depth into all of the connection planning stuff, but I want you to be able to have this because this material goes through, well, how do you help someone think about this? I'll briefly talk about the cognition part because it's one of the less, I think, straightforward parts. But if you were asking someone, well, what thoughts go through your mind when you're feeling really lonely? And for me, I might have said something like, oh, well, I was thinking about missing my cat Mitzi, but I just can't stand losing someone else I love, and I'm just too tired to adopt a cat. And then you might pay attention to those thoughts and how they're driving my loneliness. And we might think about how we could manage those thoughts. Are there simple things I might be able to tell myself that might help me get unstuck? So here are some prompts that are useful in developing helpful self-talk for a connection plan. Like, how can I view this situation from a different perspective? Or think about someone optimistic. I value their perspective. Or I can remind myself, don't believe everything you think. And again, briefly, physiology is a key part that we often don't address in our social connection interventions, but can be really important. During the pandemic, if someone couldn't have human touch, that's dysregulating. It's frightening. We feel unsafe. So things that we can do, like touching grass or feeling snow. There's also the fact that if we're feeling very socially anxious, we may not want to go out and be around people. So we want to regulate our nervous system, remind ourselves that we are safe before we may feel comfortable doing some of the things that you might put on a connection plan, like getting out and being around people. So helping someone understand what they feel in their body when they're feeling lonely and isolated can help, that you can then help them counteract that so they can feel more ready to do those things. Here are some things you can do, like self-soothing, calming activities, changing your temperature. I'm going to leave those for you to go through so we can have some time to talk in conversation for at least a few minutes. And finally, the last part of connection planning is the stuff that we think about when we think about connection interventions. It's doing new behaviors. So brainstorming ideas to address the piece of the pie, problem solving logistical barriers, picking a small piece to start with. Not trying to jump to volunteering, maybe starting with just sitting out on the front porch. And finally, thinking about is experimenting with new behaviors just to see how they go. So here's my connection plan that, like I said, led to me getting those two little furry goofballs, things that I might have done or that I did do when my body was dysregulated. For me, it's bike riding or sitting in my garden if I'm feeling really lonely. For the mind, the thing that really worked for me was letting myself believe that adopting a new cat would take a lot of energy, but it would also give me a lot of energy in terms of love. And then things I could do, ride my bike to a friend's house, explore volunteering options. I thought about that, doing like therapeutic riding. And then what I went with was seeing if a friend would meet me at a cat cafe. And the rest was history. So I do have example in here of a connection plan with an older person. You'll have these slides, but you can we can also come back to it for Q&A if you'd like an example of what this might look like with an older person. But the reason I gave you my example is I think the best way to try this stuff out is actually to go ahead and do one for yourself. So I wanted to give you an example of what mine looked like so you could try it for yourself. But you will have that example of a cognition that might be especially salient in an older person, like I'm being forgotten by my family, how you can address that in a few ways, how you could then maybe help someone with the physical sensations, like teaching exercises to slow breathing or imagery, behaviors, trying new things. So maybe connect with church members and family. And what a connection plan might look like for an older person. So you'll have all of those resources. I'm also going to give you a link to a free training that you can do on connection planning that I developed with my colleague that will really help you go through all of this in a little more detail in terms of what it looks like in doing it with an older person. My co-creator of that is Dr. Emily Bauer, who is a geropsychologist at Pacific University out in Oregon. And here is that link to the training. I'll also try to put it in the chat when I stop sharing so that you can do that. We have two trainings. One is if you're delivering in primary care, and then another for long-term care settings where you might involve the whole care team. Finally, just a quick plug for all the work we're doing in the Hope Lab. I'd be delighted to tell you about any of it. We've studied peer companionship, volunteering, robo-pets, connection planning I told you about, communication coaching with an avatar. And we also have connection coaching is the one I mentioned that's a little bit longer term than connection planning. So it's about 10 sessions. Finally, more resources for late life suicide. I recommend the E4 Center. We have clinician resources there, and my colleagues have lots of things that you can use to work with older suicidal patients. There's also a resource guide that I helped them develop with resources that are grounded in those 5Ds. Finally, I want to thank my colleagues at the CSPS and leave you with one of my research participants who said the intervention was so helpful because she realized that when she was connected to others, there was hope. So nothing better for the Hope Lab than to be told about the importance of hope. So I'm going to stop sharing there so that we can hopefully have a conversation for a few minutes at least, and I'll put some resources in the chat for you.
That's awesome. Thank you so much. And that was a really, really helpful presentation. Like I think it, for the community that's listening, it's like the importance of social connection just cannot be just like overemphasized enough. It's such a big piece. And it's something that we can actually very much do together, right? And to support each other in it. We have a couple of questions from folks. But I'm wondering, like, even on that front around, I feel like there's like a perception of what socializing looks like. And I love that you said we're not trying to make you extroverts.
Yeah.
And that introverts socialize, but they socialize differently.
Yeah.
And I'm wondering if you could maybe speak to that a bit.
Absolutely. I think there's so many different ways to meet our need to belong, and it doesn't have to be being around tons of people. It can be whatever works for you. Even things like I worked with an older gentleman who'd been isolated for so long, and he was terrified of making any changes. And what ended up being the thing that he started with was just going to a garden, a nursery, and getting some plants. Now you
Mm,
think about that as like that was social connection, but he was around some people, and then there's something about nurturing plants. And so
yeah.
the idea of connection itself can be broader. So connection to
Yes.
ourselves, connection to something bigger, all of that can be life-saving as well. So it doesn't just have to be with another person.
Yeah. I remember being also like at a silent retreat, and I was sitting next to someone. We are just having tea together, not speaking. I
Yeah.
was like, oh, that was so rejuvenating. Could just sit with someone, but I don't have to talk to you, but I still had a sense we were to kind of together. Almost maybe if you're at a library and everybody's reading together in the same room, it's kind of maybe have the same effect.
Yep. Yep.
Yeah. Yeah.
I think
Um,
connecting with parts of your identity. It was a wonderful person in our coaching program who that was one of her goals. She wanted to reconnect with parts of herself. And for her, that was going to a farmer's market and just being
Yeah.
in that another.
Yeah.
Yeah.
Yeah. Yeah, for sure. Yeah. Um, so there's some questions from the audience. One is from Talia. She's asked, she also says, thank you for your work. You're a huge influence on her master's thesis. And she says, what are additional considerations about connection planning for older adults who have estranged relationships with their children?
Absolutely. That is a tricky one for sure. I will say when we do our longer interventions, even those are not super long and they're probably not going to completely change any of that. But I will say, with our older people, we have found that we can build up other parts of those of their worlds. And so we've been doing actually assessments with smartphones where we ask people in this moment, do you feel lonely? And
Mm,
found lots of changes in terms of that. And people talked about things like moments of authenticity, of being around other people and feeling seen. So while our intervention didn't necessarily change these long-standing dynamics, we were able to give people these moments of joy and authenticity.
mhm.
And so I would say if I'm working with someone at risk for suicide, I would target the lowest hanging fruit, which might be some of those moments of joy and
Yeah.
authenticity. And then if you have longer, yeah, working on some of those longer standing dynamics that may take some family therapy and things like that to address.
Yeah, I think it kind of speaks to the fact that a lot of these experiences that people have, these moments of joy, are also cumulative. It's kind of like how you have like long-term self-care strategies and short-term self-care. Like doing a little bit over time actually does make a difference, and we do see that. So I'm hearing that as well. Um, Another question is around what are some of the biggest challenges you think currently exist in this field, like suicide prevention for older adults, and how do you think those can be addressed? Quite a big question, but see how you
Yeah,
want to tackle that.
I, I think I would put my money down on ageism. So ageism among providers as well. And I see that in a lot of different ways. In the outpatient clinicians I work with, um, they're only seeing the people who struggle. You know, the
Hmm.
people who are doing really well don't come to their offices. And so they can
Hmm.
forget that, wow, actually, most older people are thriving. And so I
Hmm.
think reminding ourselves actually over and over that later life tends to be a time of greater well being.
Yeah.
That's not discounting the stresses, but there are some really beautiful things that can happen with aging and remembering they're both there. I think ageism and healthcare providers can be a real thing. There's a lot of
Mhm.
compelling data showing that even in hospital settings with universal suicide risk screening, older
Yeah.
people are screened less.
Oh, really? Okay.
So I
Wow.
think if we could do some things to combat ageism, I think we'd
Yeah.
have a lot of bang for our buck.
Wow. That's amazing. That sounds like a really good direction for sure. A lot of research doesn't focus on biases in clinicians, and I think that that is an important piece, right? Because we're the ones doing the work. Maybe as a last question before we hit it, because I know that a lot of people probably have this question, and everyone's increasingly online. And do you see that there's like a difference? I guess there's a two-parter here. One is there a difference in connection in virtual space versus not? And there's also this part where people are increasingly online and becoming less interpersonally connected in person, and that's also having a certain impact in the opposite direction. So, yeah, what are your thoughts on that?
Yeah, I think like at any age, it's how we use it. And I
Yeah,
think there are a lot of benefits. I think when I'm working with older people and in our programs, we say, if you can be in person, great. But if not,
yeah,
face to face, being able to see the other person's reactions
yeah.
and body language is so also cognitively stimulating. So that's
Yes.
a whole other conversation we could have about the cognitive benefits of social interaction. So
Right.
having video on is key. But if someone can't leave the home because they have mobility impairment, they can get lots of connection through, I think, using online strategies. And I wouldn't discount that. I would also say with older people, there are lots of scams and things like that. So there are some
Mm,
really good resources for helping older people who are lonely not fall victim to internet scams as well.
right. Right. That's a really important point as we're kind of increasingly online and you're also working with vulnerable populations too. So that's a scary one. But also just the idea that you can actually use online communities as a resource as well, and even like even if it's like a, I don't know, a Reddit chat group or things like that can be helpful. Kim, thank you so much for this. Like, there's all these comments in the chat saying how wonderful this was, and the people got some really good practical tips, and this was really, really helpful. So thank you so much, and thank you for the work that you do in this area and in social connection. Like, it's such an important part of the puzzle, and I've followed your work for many years. So I was very, very excited that you're willing to speak to everyone about this. So thank you so much.
The delight.
Yeah. And for everybody, we will be having our next session together on April 13th from 12 to 1. Our Dr. Katie Dunlop's going to be speaking on biological markers of risk factors for suicide. So we're going to go to a whole other direction. So lots to talk about. But everyone have a wonderful day. And thank you so much again, Kim.